Harvard Divinity School.
Spirituality in Serious Illness and Health. Implications for Spiritual Care of Patients and Communities. February 1st, 2023.
Welcome, everyone. Welcome. We're so delighted to have you here tonight for this very special presentation. And I'd like to introduce myself. My name is Laura Tuak, and I'm an Assistant Dean in the Ministry Studies Office. And I'm here just to gather us in. So as we get started, just invite you to kind of gather your energy in, bring it in together with the people around you. Maybe take a breath. You've arrived, and people will still be arriving. I just wanted to take a moment to acknowledge that all of us have come tonight for our own reasons, right? That may be professional. We may be caring for people who are seriously ill. We may have this as our life's work to bring spirituality into our various disciplines. I'm thinking of some of the people up here on the panel. Or maybe you yourself have been seriously ill and have grappled with spiritual questions, or someone you love has been seriously ill and grappled with these questions and hoped for more in their care while they were receiving it. So tonight, we're all here to listen and to learn, and perhaps to envision a future where these recommendations that our authors have put forth may come to reality. So as we gather in this moment, we'd also like to invite you to join us as we lift up the Harvard University Native American Program's acknowledgement of the land and people. As this community, committed to becoming anti-racist and anti-oppressive, at Harvard Divinity School, we remember and acknowledge that Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. So we pay respect to the people of the Massachusetts tribe, past and present, and honor the land itself, which remains sacred to the Massachusetts people. But for the stolen land and stolen labor, this country and this university would not be. Our acknowledgement of the land and people extends beyond words. It is expressed through our actions here at Harvard Divinity School and our actions tonight by advancing the critical work of healing that we will engage in tonight's program. I'd like to call forth Dean Hempton of Harvard Divinity School to do the official welcome. So, thank you, Dean.
Thanks, Laura, very much. Welcome, everybody. Thanks for being here on a pretty cold evening. It's great to see you in our new finery and our new spaces. So thanks for joining us. I'm delighted to be introducing tonight's panel session, and also very grateful to our friends at the Initiative on Health, Spirituality and Religion for co-sponsoring this event. Illness is often described as a form of exile or alienation from the world. In Illness as a Metaphor, Susan Sontag, who I think may have been suffering from breast cancer at the time, compares illness to a second citizenship, one that we take up when our citizenship in the kingdom of the well is suspended. She writes, illness is the night side of life, a more onerous citizenship. Everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use only the good passport, sooner or later, each of us is obliged, at least for a spell, to identify ourselves as citizens of that other place. The sick body is a body that ceases to cooperate with one's deep desires and aspirations. It rebels and isolates one from others. The sick become strangers in a world of healthy people. How can we ameliorate the exile of illness then? This question has been a driving force behind a renewed interest in the integration of spirituality into healthcare. Over the past 2 decades, researchers have taken great interest in the provision of spiritual care to patients, a vital complement to medical care that patients ordinarily receive within our health systems. Importantly, spirituality is not a foreign concept in healthcare, despite recent trends towards secularization and economic rationalization. The earliest hospitals were all-purpose institutions that provided not only healthcare, but also lodging and spiritual attention for travelers who were far away from home. They were a place of welcome for strangers, hospes, who were in a foreign land. There's a sense in which renewed emphasis on spiritual care is part of a rediscovery of a wisdom that underpinned the very first healthcare institutions. And that would be true of Christianity, Islam. There have been several positive developments in the practice of clinicians in recent years that reflect a recognition of the importance of spirituality in human health. Many doctors now take a spiritual history of their patients when conducting a first consultation. Other doctors simply ask their patients one question: what role, if any, does faith or spirituality play in your life? Recently, a systematic review of the medical literature on spirituality and health was led by researchers at Harvard, some of whom are right here, synthesizing key insights and utilizing an expert panel to assess evidence and make recommendations about the integration of spirituality into care for patients with serious illnesses. The operationalization of these recommendations in the context of chaplaincy and therapy is really the subject of this evening's discussion. And it's wonderful to see 2 HDS graduates joining our panel. The Divinity School is proud to be playing a part in educating the next generation of hospital chaplains who will provide sensitive and inclusive spiritual care to patients from all faith backgrounds and those with none at all. It's also wonderful to see such a diverse range of perspectives represented in the audience tonight. We're looking forward to a rich Q&A and would encourage in particular practitioners who minister to minority communities to offer their perspective on the research under discussion tonight. So it's now my privilege to introduce the moderator of tonight's event, Dr. Howard Koh. Howard is the Harvey V. Feinberg Professor of the Practice of Public Health Leadership at the Harvard T.H. Chan School of Public Health and the Kennedy School, as well as faculty co-chair of the Harvard Advanced Leadership Initiative. From 2009 to 2014, Dr. Koh was the 14th Assistant Secretary for Health for the U.S. Department of Health and Human Services after being nominated by President Barack Obama and being confirmed by the U.S. Senate. During that time, he oversaw 12 core public health offices, including the Office of the Surgeon General and U.S. Public Health Service Commission Corps, 10 regional health offices across the nation, and 10 presidential and secretarial advisory committees. Sounds like a lot of work. He served as Senior Public Health Advisor to the HHS Secretary, and in that capacity oversaw the Healthy People 2020, the nation's public health agenda, and promoted the disease prevention and public health dimensions of the Affordable Care Act, advanced outreach to enroll underserved and minority populations into health insurance coverage, and he helped to coordinate federal response during the 2009 H1N1 pandemic, and was the primary architect of landmark HHS strategic plans for tobacco control, health disparities among various communities, and chronic hepatitis. Dr. Koh has also a dedicated interest in the topic of spirituality and health, and has published and lectured extensively on the role of spirituality in health and the role of spirituality in leadership. He's written extensively about the profound influence that Yale chaplain and peace activist, the Reverend William Sloane Coffin, had on him as a college student and medical student. On a personal note, I want to pay tribute to Howard's friendship to me and to the Divinity School, and to say how very delighted I am to see this work and this event hosted by the Divinity School. Howard sidled into my office, must be the best part of 8 years ago, I think, and when I hadn't been dean for very long. And we talked about this kind of thing, you know, how we could bring together the spiritual dimensions of what was going on in the Divinity School with the public health dimensions and the training of leaderships in the Chan School and in other places at Harvard. So to be in these new spaces, to be connected in this way, this evening has been a little bit of a dream, I think, over a period of time. So Howard, we're really thrilled to have you here, and thank you for your friendship and support of this school. Over to you. Thank you so much.
Thank you so much, Dean Hempton, for your leadership and your kind words. And it is so wonderful to be standing here before you and seeing this wonderful crowd. And Dean Hempton, I just want to start by thanking you personally because you heard my bio. Thank you for reading all those details, by the way. But when I came back from DC to rejoin the Harvard faculty for the second time, I went into Dean Hempton's office. It was about 8 years ago. I remember it so clearly. It was a cold winter day. There's a fireplace going on in your office. And I said, Dean Hempton, you don't know me, but I'm a physician who's thought about the intersection between spirituality and health pretty much my whole life, starting when I was a college student, listening to Reverend William Sloane Coffin preach. And I think I'd like to try to explore that intersection a little bit more now that I'm back in academia. And I held my breath, and I'll never forget the reaction because Dean Hempton was so supportive, so enthusiastic, so encouraging from that moment. And he said, I'm going to work with you. I'm going to support you. I'm going to help you. Please continue. So it took a little while, but here we are, this beautiful, beautiful space. And then in the meantime, I've met many, many wonderful colleagues who have joined in this still fledgling Harvard initiative on health, spirituality, and religion. But we're very proud to introduce all of them to you and thank all of you for being here to explore this fascinating area that has so much relevance right now, especially in a time where spirituality is something that we all need to talk more about in this era of COVID. Before I go on, I want to thank our dear friend Laura Tuak, our Assistant Dean for Ministry Studies here at Harvard Divinity School. She just opened up this session. Big round of applause for Laura, by the way. We are very lucky to have a new and very productive coordinator on our initiative for health, spirituality, and religion, Xavier Simon. Xavier, please raise your hand. Xavier has put out, I think, hundreds of emails to get all of you together here tonight. And then we have a very vital member of our initiative team who will not be speaking, but he is world famous. Can I just tell you, Dr. Tyler Vanderweel? Where's Tyler? Can you just wave and stand up? Tyler is a brilliant biostatistician, epidemiologist, has done dozens, maybe hundreds of key studies that we're going to be referring to tonight. And he leads a very exciting Harvard Human Flourishing program here, which is attracting colleagues from around the world. So we're very proud to have Tyler tonight. I also want to acknowledge the tremendous support of the Human Flourishing program and the initiative by Dr. K.J. Lee. Dr. Lee, can you just wave and raise your hand here? And this initiative is now meeting and coordinating events, and this is a major one for us, and so we're very, very proud of it. So we're here tonight because, as Dean Hempton mentioned, about 6 months ago, a landmark research paper on spirituality and serious illness and health was published in the Journal of the American Medical Association, JAMA. You hopefully have all seen it or have access to it. It really represents a comprehensive piece of academic work that has also been reviewed by an expert panel. And so we're going to be hearing about that work. I had the privilege of being a co-author of about a dozen on that piece. But Dr. Tracy Balboni is our first author and leader on that unbelievable work, which I think Tracy took 3.5 years, right, only? So it was an odyssey. It was a faith journey, but we got it up and out. And now that it's out, we wanted to present it to an expert panel. that I'll be introducing in just a second, and then hear your reactions about implications for the future of health and spirituality and religion and for our society at large. So that's what we're going to be doing today. I'll be introducing Tracy. She'll be speaking as our keynote speaker for about 10 minutes. We'll have each of 4 panelists then share some personal and professional reactions to that, and then open it up for Q&A. Finish around 7, and then we have a wonderful reception just around the corner that Dean Tuak will be telling us more about. So that's the agenda for the rest of tonight, okay? So first and foremost, we're hearing from Dr. Tracy Balboni, the lead author on the JAMA paper. She is a professor of radiation oncology at Harvard Medical School. She's also the Institute Physician in Radiation Oncology at Dana-Faber Cancer Institute. She's program director for the Harvard Radiation Oncology Training Program and is a co-director of our initiative on health, spirituality, and religion. And if I can say, it is a privilege for me to have gotten to know Tracy and to work with her for these years and see her brilliance and her compassion and her absolute dedication to this area up close and personally. It's just a privilege to join you on this, Tracy. So we'll be hearing from you first. And then we are going to be hearing from our panelists. So let me introduce them formally now. To her right is Reverend Dr. Gloria White Hammond. She's a physician and a minister. She does it all. She's the Schwartz resident practitioner in ministry studies at Harvard Divinity School. She's co-pastor at Bethel AME Church in Boston. She worked as a pediatrician for 27 years before retiring in 2008. And if that's not enough, she also runs a human rights initiative that partners with diverse Sudanese women in their efforts toward reconciliation and reconstruction of their communities. Round of applause for Dr. Gloria White Hammond. And then to her right is Anna Gosline, the executive director of the Massachusetts Coalition for Serious Illness Care and vice president of the executive office of Blue Cross Blue Shield of Massachusetts. Anna has a big job, works on many issues in health, a diverse portfolio that includes policy, community, and communications projects that touch on topics ranging from payment reform and healthcare costs to the opioid epidemic. Big round of applause for Anna. To her right is Reverend Ali Jablonski. She's a minister and director of spiritual care at Tufts Medical Center. She's a graduate of the Masters of Divinity program here at Harvard Divinity School, so it's great to welcome her back to this campus. Big round of applause for Anna. And then to her right, last but not least, is another new wonderful colleague for me and a great colleague on the initiative, David Rosbrin, who is a PhD, director of the Spirituality and Mental Health Program at McLean Hospital, associate professor in psychology in the Department of Psychiatry at Harvard Medical School, and a wonderful new colleague. So a big round of applause for Dr. Rosbrin. So Tracy's going to speak for about 10 minutes and give a very quick summary of this massive piece. Did we have a round of applause for Tracy, by the way? The whole purpose of tonight is to show appreciation. Said, hey, actually, this piece is actually out. Now we can talk about it, okay? So Tracy, please come up, and thank you so much for your leadership and commitment.
Wonderful. So it's what a joy to be here with all of you tonight. Thank you, Dean Tuak. Thank you, Dean Hempton, for your warm hospitality here for all of us on a cold evening. And thank you, Howard, for just a kind introduction to me and to all of us tonight. To our evening. So my task tonight is actually to orient us to this paper, this study, a systematic review on spirituality in serious illness and health, published in JAMA in July of last year. And as you can see, we had quite a team involved. In fact, many more than you even see on the author list here were involved in making this research work possible. And as Laura alluded to before, we each have our own story in why we are doing this sort of work. And I'm just going to take a moment to share with all of you my own personal journey of how I arrived at doing this research work. And I'll take you back about 20 years when I was a medical intern. And early in my medical internship, I began to have these experiences, which just highlighted to me and sort of confronted me with the fact that spirituality plays such an important role in the lives of my patients, and yet the medical system and the way I was trained as a medical practitioner was completely blind to that fact. So I remember one particular patient. I had quite a list of patients I was caring for as an intern, and this particular gentleman was a young gentleman in his 40s with metastatic esophageal cancer. He'd been diagnosed about 6 months prior, and he was undergoing cancer therapies and had every complication you could imagine from his cancer therapies. And of course, as a result of that, was admitted to the hospital. And I was caring for him and spent a lot of time with him because of the sheer complexity of his care. And one morning, I was gathering the data that I needed in order to kind of report back to our team on rounds, and I was kind of hurriedly trying to get through all of that in the room, and he stopped me. And I will never forget his demeanor and the conviction with which he said these words to me. He said, "If I had known that it was going to be like this, I would have shot myself. If I had known that it would have been like this, I would have shot myself." And as you can imagine, I was, stopped cold in that moment. And of course, we as a team attempted to now, address this suffering that this gentleman was expressing to me. But it also just hit me that I had been, working so hard, so fastidious with my check boxes and all the rest, trying to address all the complex elements of his medical care. And yet I had missed completely the largest source of his suffering. I had completely not even seen it. And it was events such as these early in the course of my medical training that made me realize, oh my goodness, what makes us so blind that we don't see this aspect of our patients? And that I began to embark on, actually one of the first things I did is I did a short elective in shadowing chaplains during my internship. They allowed me to do this, which was really a gift, to learn about the role of chaplaincy. And then ultimately that resulted in research work, and then finding others doing the research work, including in serious illness and in public health, as you've already seen today, including folks like Tyler Vanderweel and Howard Koh, and among others, many on our panel here today. And now 20 years later, here we are with this research work that I'm going to orient you to now. So I'm going to begin with the question of why. Why did we do this project in the first place? Well, there's growing research on the role of spirituality in illness and health, but there's been fairly little uptake into healthcare. And of course, I've listed a couple of possible reasons here. First, this research work often doesn't get into high-impact journals. And though improving, there continues to be a good deal of bias against the recognition of the role of spirituality in health. That being said, there's evidences of some hope. So there's increasing recognition of the role of spirituality as part of health. And I would argue that even in the 1948 WHO definition of health as not merely the absence of disease or infirmity, and though it doesn't name the spiritual, it begins to imply the spiritual. And then later, and more recently in 2002, when the WHO defines palliative care, it does indeed name the spiritual as a key component of health. So this project aimed to provide a comprehensive assessment of all of that literature in spirituality and health, both for ill populations as well as healthy ones, and using that evidence to name the implications of that evidence for the practice of medicine, employing, of course, experts in the field in order to help us to understand what those implications should be. So these are the project methods. So bear with me as I take you through this, but this actually is important. So we began with systematic reviews of all of the literature from the year 2000 to the present day in spirituality and serious illness, and spirituality and public health. I'm just giving you, again, this is a detailed slide, but just to give you a sense of what this includes. So for example, if you can see my cursor here, we reviewed over 15,000, nearly 16,000 papers on spirituality and serious illness, and combed through them, picking the most robust, strongest evidence in order to arrive at what ultimately was 441 papers in spirituality and serious illness. In health outcomes, a very similar process was undertaken. Over 12,000 papers were reviewed, and following that same kind of process of extracting the most rigorous data, we arrived at 276 total papers over that 23-year period. Next, we assembled a Delphi panel. So a Delphi panel is a panel of multidisciplinary experts with the requisite expertise to assess the evidence and then to say, what does this evidence tell us about what should be recommended for the practice, in this case, of care within medicine and public health. So we provided that synthesized evidence to our expert Delphi panels, and they said, this is what we see in the evidence. These are the key evidence findings of this literature. And they said, these are the key implications of these evidence for the practice of medicine in serious illness and in public health. These are our Delphi panelists. So there were 15 in public health and 13 in serious illness, again, representing many disciplines and the requisite disciplines for really being able to speak to this topic. Next, the research team analyzed that qualitative data, those evidence statements by our panel, and synthesized them to come up with distinct evidence statements in each of the categories: spirituality and serious illness, spirituality and public health, and then did the same for the implications of that evidence for the practice of medicine and the practice of public health. And then we went ahead and we returned to our panels and had them quantitatively assess the strength of the evidence behind each of those evidence statements and had them rank the implications of that evidence for the practice of medicine. So I'm just providing you an example from one of the tables in the study. So just highlighting here, this is one of the evidence statements. Religion or spirituality are important for most patients with serious illness. You can see that we had 13 Delphi panelists. All of them rated the evidence behind this statement as strong. So they agreed that it was strong evidence. And they did this sort of similar quantitative assessment for those evidence statements in spirituality and public health. And they also ranked the implications of this evidence for in both spirituality and serious illness and spirituality and public health. So we then assessed that data, and now I'm going to provide you with what those evidence statements were. So spirituality and serious illness, there were 8. I already mentioned this one to you. Religion or spirituality are important for most patients with serious illness. Spiritual needs are common. Spiritual care within medical care is frequently desired. Spiritual needs are frequently unaddressed. Religion and spirituality can play a role in medical decision-making. Spiritual care is infrequent in the medical care of patients with serious illness. Provision of spiritual care to patients with serious illness is associated with better end-of-life outcomes, and unaddressed spiritual needs are associated with poor patient quality of life outcomes. Interestingly, sort of coincidentally, there were 8 evidence statements deemed supported by strong evidence in spirituality and population health, and these included that frequent religious service attendance is associated with lower risk of mortality. It's associated with less smoking and less use of substances such as alcohol, marijuana, and illicit drugs. It's positively associated with subsequently higher quality of life. It's associated with better mental health outcomes. There's actually a dose-response relationship between religious community involvement and lower risk of mortality. Among adolescents, service attendance is associated with less smoking, less risky sexual behaviors, and use of substances. And service attendance is also associated with less depressive symptoms and less suicidal behaviors. So those are our 8 evidence statements, both in serious illness and in public health. Now the implications. The implications of this evidence in serious illness were named as that we should routinely incorporate spiritual care into the medical care of patients with serious illness. We should include spiritual care education for members of the healthcare team, and that we should include specialty practitioners of spiritual care, chaplains, in the care of patients with serious illness. In spirituality and public health, we need to be incorporating patient-centered and evidence-based approaches regarding the beneficial associations of spiritual community participation into efforts to improve health within medical care as well as community settings. We need to educate our public health professionals of this evidence. and also recognize spirituality as a social factor associated with health. So just to summarize, this is a whirlwind tour. We have 8 evidence statements in serious illness, 8 in health outcomes supported by strong evidence. And this evidence has a number of key implications. And interestingly, there are some parallels between serious illness and public health. Inclusion of spirituality, we're recommended to include spirituality in the care of seriously ill patients and also in the care of communities. We need to be educating our healthcare teams and also providing education within public health settings. And we need to be including chaplains in the care of the seriously ill, and we need to be including spirituality as a social factor associated with health in public health efforts. So I'm just providing you here, there's a number of people who made this work possible, a number of key supporters, and I do also just want to say thank you once again for those that are making this evening possible, and particularly the warm hospitality here at Harvard Divinity School. And I'll pass it on to our illustrious panel.
Thank you so much, Tracy. And you heard in 10 minutes, 3.5 years of work. You can tell this is a Herculean lift, and we are so in awe of Dr. Balboni's commitment to this. What a great, great project, and we're all so proud of you, Tracy, and this great team effort. So now, what do we do? What's the reaction from our esteemed panel, and then from all of you, and hopefully others around the country and around the world? So our first panelist will be Reverend Dr. Gloria White-Hammond. Gloria, why don't you come up and give us about 5 to 7 minutes of reactions to this, and then we're going to hear from your colleagues too. Please step forward. Please. Round of applause for Gloria White-Hammond.
Thank you. Well, I come to this conversation in general as a community-based faith leader who also happens to be a community-based physician, and as a pastor of a local congregation that is largely African American. When I think about the implications of this critical conversation about quality of life of patients in communities affected by serious illnesses, I get extremely excited about this research and about the possibilities of the way forward. And I'm going to offer to you what I consider Exhibit A. 6 years ago, my beloved friend Margie was diagnosed with breast cancer, and among Margie's many enduring qualities are her extreme boldness in declaring her testimony to anyone, anywhere, anyhow. And she asked if I would accompany her to her initial visit with the oncologist. As we waited in the examining room, it was clear that Margie was extremely anxious. She asked if I would pray. She said that the one thing that she wanted the clinicians to understand was that she really believed that God had healed her of this cancer. And so we joined hands and prayed together, and as we finished up with a hearty amen, the nursing assistant, the patient care assistant, came into the room and began interviewing her. She positioned herself at the computer and asked Margie her name, and then asked if she knew why she was at that space. Well, of course, the simple answer was that she had come to be evaluated for breast cancer. But Margie launched full throttle into Friday night testimony and shared that they said that she had cancer, but God said she was healed. She expressed how she had been saved, sanctified, and filled with the Holy Ghost, the date, the time, and the place, how she had been running for Jesus ever since, and she knew that God was surely in the blessing business. Meanwhile, the assistant has her hands positioned over the keyboard and looked utterly stunned. And I worried how she would respond, if she would respond. As Margie continued to talk, however, I noticed that her body softened. It was as though a light had come on in an aha moment. When Margie concluded by saying, "And I know God is able, thank you, Jesus, hallelujah," The young woman put her hands in her laps. She leaned over and with a tentative smile and a measure of curiosity in her voice said, "So, you're spiritual, right?" And with that, Margie, it's like the air, the anxiety left her body. She laughed and she said, "Yes, I'm spiritual. That's right." I would submit that in that moment, that young nursing assistant not only appreciated the intensity of Margie's testimony, but she appreciated that Margie's spirituality was core to her identity and was going to be critical to the way she responded in terms of her medical decisions. I have been gratified over the years as I've continued to explore this intersection between medicine and spirituality. I continue to travel with Margie during her visits, and I can say without a doubt that everywhere Margie went, she let her little light shine. And I was so gratified by the response of the Dana-Farber staff. As it turned out, the cancer returned, and at some point she underwent chemotherapy. When it was clear that the side effects were such that she couldn't endure them, she declined additional treatment. She said that she knew where she was going, and she wasn't afraid to go there. And so she died some 6 months later. Margie died on February 2nd, 2020, at home with her family providing their hospice care. And the thing that I continue to appreciate was the extent to which her family continues to celebrate the staff at Dana-Farber for the extent to which they honored their mother and treated her well. So this conversation is critical not only to me and not only to Margie, but to so many people. According to the 2021 National Public Opinion Reference Survey study by the Pew Research Center, 66% of US adults consider religion to be very important or somewhat important. Among African Americans, that number is 80%. For many people, spirituality is not just what they do, it is who they are. If we couple that reality with the evidence of improved quality care when spiritual needs are identified and addressed, Tracy, we can appreciate the importance and the efficacy associated with training diverse clinicians and hiring diverse spiritual caregivers to address spirituality. The same way that staff are trained to explore medical history and review of systems and social history, they can also be equipped to ask about spiritual histories, much like I suspect that nursing assistant was. And what's interesting, it can take you a while to ask those questions. What are the sources of hope? Do you identify with a particular religious tradition? Are you part of a given community? What are some of the practices that are important to you? And how might I, as a clinician, address your spiritual care needs? It can take a while to answer that question, but in Margie's case, it only took, and what is it that brings you here today? Hallelujah. Thank you, Jesus. When there's a need for more specialized caregiving, we can call on the chaplains or other spiritual caregivers who are part of the team, and we should. And we need far more chaplains in hospital systems than we have. And we ought to be able to bill for them, and we ought to be able to pay for them.
Yes.
Can I get a witness? And where that individual identifies a community of faith, a congregation of faith, I think it's important to ask individuals, would you like me to engage with your spiritual caregiver? This is one of the ways that I often show up with my congregants when they get sick, is that they ask if their pastor can be a part of the conversation. So that it's important to make that connection on behalf of the patient. I'd encourage you to think about doing that again with the support of chaplains or spiritual caregivers who are part of the institution. I think it's also important to nurture relationships with community-based clergy at large. If we didn't figure that out before, coming through the pandemic, those kind of relationships really make a difference. Several years ago, the chaplaincy staff at Brigham and Women's partnered with HDS and HBS, imagine that, the Conversation Project, and particularly I was appreciative of the palliative care team at Brigham and Women's. And we sponsored a couple of different forums for community-based clergy, both of which had waiting lists for attendance. We had over 100 people and people on waiting lists. And one of the forums was about end-of-life care and how community-based clergy can support their members to have conversation about end-of-life care. At Bethel, we have literally supported hundreds of individuals to engage in this conversation. Another forum was about serious illness care and what spiritual caregivers can do to support members in their congregation who have serious illnesses. So there are all kinds of possibilities. And during the pandemic in 2021, we hosted the chaplaincy staffs at Mass General, Brigham and Women's, and Beth Israel Deaconess, sponsored a virtual forum on how to support patients who have COVID-19. So again, we have a number of possibilities. And I want to encourage us to think in particular to reframe how we think of hospital institutions. And I had a wonderful colleague who is both a Muslim sheikh and an ER doc, Dr. Khan, who says that we typically think of our hospitals, our health institutions, by default as secular institutions. But when you consider how many people operate in a religious framework and consider spirituality to be critical to their identity, it's not really so much a sacred, a secular space as it is a shared sacred space. Just like Jesus was in the room for Margie, Allah is in the room for a Muslim, or Buddha is in the room, or the Great Spirit is in the room. And so the opportunity now is to think through the reality for what many people is, and to reimagine creating more sacred spaces for people to engage when they come to the clinic. A couple of years ago, I had a student who was interested in architecture, and I teach at the medical school, the Divinity School, and the School of Public Health. And he designed waiting spaces for people to be able to wait, again, with diverse symbols and encouraging people as they not only sit there waiting with anxiety, but call on their deities. So we can do this, and when we do it, I hear Margie saying, hallelujah, thank you, Jesus.
Thank you, Gloria. That was so powerful. Thank you for starting us off so well. Next, we're going to hear from Anna Gosline. Anna, big round of applause for her, please.
Okay, tough act to follow. So my organization is the Massachusetts Coalition for Serious Illness Care. Thank you for the kind introduction. It is so wonderful to be here. I come at this sort of professionally as largely through a lot of the consumer research that we've done, a lot of experience research about patients and their perspectives on kind of going through serious illness journeys. We actually do a lot more than that. We partner with our state's medical schools to try to up the bar on kind of communication skills that we think all medical school students should graduate with for serious illness care. We have a similar project with nursing schools, and we also partner with state government on some of our big serious illness care projects. But again, I think the thing that we're most known for is consumer research. And me personally, how I'm showing up in this space is sort of as it really feels like a humanist tradition to me, and that is a tradition that I learned through being part of this research over the past 7 years. So I'd say we do this research. It tends to be really large-scale national surveys. And we complement that with pretty large-scale qualitative research surveys. That means we get a couple of hundred people, and they hang out with us online for a couple of weeks where we ask sort of more deep, rich questions about their experiences with healthcare. And it also means we get to do things like test language and messaging and concepts a little bit more organically. We do all of this work because we want to understand how to improve the care for people with serious illness. And we do all of this work centering equity because we know that people of color, low-income people, people with disabilities, and people with language barriers, to name a few of the identities people come in with, experience worse outcomes. And so our best chance to really understand how to improve care is to focus on the needs of those people. So, and in this research over the past 7 years, we've asked about faith and spirituality many times. It shows up in a lot of nuanced ways, as I'm assured none of you would be surprised. Our most recent round of research, which came out at the end of 2021, faith came up a couple of different ways. And what was really surprising is that even for people who said that faith was very important in their lives, there were some very strong reactions when they said, no, I want my medical care kept very separate from my spiritual care. And it was surprising because in different elements of our research, we knew that it was very important. We also know that people who who say that their faith and spirituality is very important to them are more likely to have engaged in things like advanced directives or conversations about planning for their future. But in this one, it was a really strong reaction saying, absolutely no, it's different. I want those kept separate. But I think the reason why we did this is we had approached our most recent research very differently. We weren't just asking about advanced directives or sort of conversations. We were asking about these much broader experiences of care. We were opening the floodgates for people to give us pretty unvarnished experiences where they had not been that great. And I think there's reasons why we saw this strong reaction. And one of them is that we have trained patients to show up in healthcare spaces as patients, not as people, not as fully formed human beings. They're sitting there and they're just focused on the little thing that is wrong, the complaint that they have come in with. And that's because clinicians are busy themselves and they're only asking about those small elements. And so no one has this expectation, and a lot of the times the clinicians are gonna ask what matters to you, what's important, what are the things that give your life joy in meaning? Because people haven't generally necessarily made the connection between the two. There's a project that's been going on for a long time called Patient Priorities Care, sort of in concert with a program that's being run out of the IHI, which is here, the Age-Friendly Health System. And it's called, they're trying to figure out sort of scripts that they could use to, especially sort of focus on older adults, to help clinicians ask questions about what matters to them so they can ground care in that first. And when you say, like, what matters to you, people are kind of like, huh? It was too abstract. It was too unexpected that in a healthcare setting, someone would ask that. So they had to start changing those questions, being like, what are the activities that give you joy in meeting? Like, what do you like doing? And then how can we make healthcare support that? But what we know from our most recent research is that most people, not most people, a lot of people feel afraid to speak up and ask questions or disagree with their clinicians because they're afraid it's going to impact their care. We know that a lot of people feel judged by their clinicians for many aspects of their identity, including faith and beliefs. And so it probably doesn't surprise you too that people of color, low-income people, people with language barriers, people with serious illness, and people with disabilities report higher frequencies of things like feeling treated like they were not treated with dignity and respect, feeling leaving appointments unsure of what actually just happened and what they're supposed to do next. And again, feeling afraid to speak up and ask questions. So then it's probably not that surprising that you would find people saying in some of our research, no, I don't want to talk about my spirituality, because clearly they could be afraid of feeling judged in those moments. They could be afraid that it doesn't feel safe to sort of create that. So all told, we're sort of painting this picture of a lack often of psychological safety. And we talk a lot about decision-making, and there's, sort of some researchy buzz terms, shared decision-making, what that kind of looks like. But if you at a sort of fundamental level don't feel safe in some space to sort of talk about who you are, it would be really difficult to implement all of these elements of bringing spiritual care, or frankly, anything else about you, into sort of care and decisions. So that's the bad side. The good side is that when we are asking people different questions about what they want, not opening the floodgates about sort of some of those negative experiences, but we're really saying, what does great care look like to you? What does that feel like? Well, then that's when people say they do want their clinicians to know. They do want them to understand. They know, and this was sort of what was kind of one of those lessons that seems like an aha, but it's really obvious. We kept on wondering, do people really know what this great care can feel like when you can feel genuinely like you can show up with your whole person? Or is that just so infrequent that no one would even think to expect it? And we asked it in a sort of series because we said we do these big surveys and then we do qualitative research and we kind of iterate back and forth because it's hard to get to the nugget of some of these really complex sort of human things. And it was true, we sort of found people really do know that that's what good care feels like. they just have very little expectation of it getting it on any regular basis. So I'll give you an example. We did one of these testing, we tested sort of language statements, and people highlight the words that sort of resonate with them and highlight the words that don't resonate with them, and we test a lot of things that way. And one of our most recent ones, we tested about 12 different sort of conversation statements a clinician could say. And again, these are sort of an emphasis on serious illness, but it's really about everybody's care. And the one that almost everyone gravitated to, sort of age, race, education, disability, caregiver status, or serious illness, it was this sense that we'll figure this out together. I will help you understand the choices as long as you help me understand what matters to you, the people, the activities, your faith, and your culture. That was what everyone gravitated to across the board. And so I think this sense of sort of collaboration and shared decision-making, we know that that's actually crucial to all healthcare. And I think what's really interesting in this space is that if we keep on thinking that this level of communication, relational skill is reserved only for the sick and the dying and the old, then we're actually going to make it that much more likely that we never get it, because those moments are really fluid. And when does an illness become serious? When is it that we need to start talking to people like they're human beings exactly? Shouldn't it be all of the time? So I think our research suggests how do we put these findings into practice is sort of, number one, this means emphasizing a very different set of skill sets with clinicians. Those wonderful clinicians who really listen, those should not be the sort of, the diamond in the rough. They should not be the needle in the haystack. That should be the kind of thing that we prioritize, that we reward. And I say this with sometimes my payer hat on the side. Like, those are the kinds of things that we know consumers are really interested in. And wouldn't it be amazing if that is the kind of way that we rewarded the practice of medicine? I think that also means it means caring for our clinicians in a different way. It's been hard in some ways doing this work over the pandemic because we know people are having challenging experiences. Trust in healthcare systems is really falling, and our clinicians are having a really hard time too. It's really difficult to show up and listen and to bring your full human self when you have 12 minutes and you're understaffed and you're burned out and all of the other things. So I think for patients, it's about encouraging them to speak up. Obviously, Margie didn't need that encouragement, but she kind of did because she needed you there. A little support to make that okay. Patients know, and patients' families know what it feels like to sort of share their truth in those moments. Like, we all know, I leave medical appointments and I'm like, gosh darn it, I didn't say what I wanted to say. I didn't ask the questions. We need a little help and encouragement, a little guidance and a little support in reminding ourselves that it's okay, not just okay, that's the way you get the best care. And even though it's not universally possible, there are access issues. We are very lucky in Massachusetts in so many ways, but it's also helps reminding people that if they are finding clinicians that aren't listening, a lot of times it is worth the effort to try to find different ones. I think it also means in all of this recognizing that there are power imbalances that underscore everything I just said. And so, people want a voice, they want to bring their whole selves, but they don't set the terms of that. You walk into a healthcare system and you are in someone else's space. And so I think, as I said, clinicians too feel like cogs in this system. But the reality is they have far more power and control to create that psychological safety that allows people to speak up, share what really matters to them, including their spirituality. That's the end.
Thank you, Anna. That was fascinating to hear all that data that you have to present from folks that you're interacting with and how to message this, what it means for patients, what it means for clinicians. That was absolutely great. So thank you so much. Next, Reverend Ali Jablonski. Big round of applause for her.
So I'm Allie, and I'm a director of a spiritual care program at one of our hospitals, but I'm very much a working director. So in addition to overseeing our department, I also I oversee different units, mostly adult ICUs. So that is very much what's informing my response to this article. So I thought I would start by just sharing a few stories and give you a few images of experiences of providing spiritual care specifically to patients who identified as not spiritual. And I'll say a little bit more about why. So this is a group of ICU staff members. In case you can't really see, they're holding a banner of chickens in tutus. So we had a young patient who needed a heart transplant, and she hated being in the city, and our hospital is in the city. And it was during the pandemic, and she couldn't have visitors most of the time. And she was waiting for her transplant and terrified. And when we talked about what is meaningful to her, she talked about her farm and how she feels so much safer around the animals with the smells that she knows and the work that she knows. And she was waiting for a heart transplant on one unit, knowing very well that if she got sicker, and when she got her heart, she would end up on a different ICU. And that was terrifying to her. And when I introduced myself as a chaplain, the first thing she said was, I'm not religious, and before you use the word spiritual as if somehow that would include me, I'm not spiritual either. So my job as her chaplain was to figure out, how do I support her in this moment, and how do I also build a pathway to make our hospital a little bit safer, knowing that she will not be on this unit the whole time. So these are the night shift, lovely ICU nurses. And I came down with my chickens in tutus, and I said, I need you to help me take this picture, because I want her to see that we, as the unit that will hopefully welcome her, we see this part of her and it matters to us. And so this was like at 10:30 at night, us holding the banner of chickens in tutus. This is our beauty squad carts, and this was not a young patient, but an older patient who had been in the ICU for a very, very long time. And as she finally started to be able to talk, she had one thing she was asking for. And I got a page that said, "Hi, chaplain. This isn't really a chaplain question, but I don't know where else to go. Can you come talk to me?" So I came down to the ICU and I said, "What's going on?" And this patient's nurse said, "My patient said the only thing that will make me feel better is to have her hair done. And my hair is usually not done." And I said, "What does that mean?" He was like, "I don't know. I just called you." So I went and talked to the patient and I said, "Tell me about your hair care dreams. Like, are we talking a cut? Are we talking dyeing your hair?" And she said, "I just want my hair in rollers. I've never used rollers." So I went back out and I talked to this different ICU staff about that. And one of the nurses said, "I used to perm all of my roommates' hair. I can do this." And so she went and put the patient's hair in rollers. And as she did, the patient talked about how going to the beauty salon was the thing that always felt grounding to her. She said, "That was my church. My mom was a hairstylist, and no matter how bad I feel, I always make sure my hair is done." So this was before the pandemic, and her husband could visit, and we all took a lot of care to come check out her curled hair. And when she finally discharged, her husband said, "I've been visiting every day, and I noticed you can't have plants here. And so I brought you this." And it was a fake plant, and on every branch was a roller. And he wrote us this beautiful card and said, "My wife said that the first time she felt more than a patient was when you did her hair." And doing her hair also gave many of us as her care providers a chance to learn a lot more about her. This is one of my favorite colleagues. This is Bob, the hospital service dog. And this is Bob with patients. So Bob has an entourage, as we like to call it, of different healthcare providers that are his handlers, and I get to be one of them. And Bob cuddles up with patients all of the time. But in the time that I want to tell you about, it was another young patient who was a nurse and who was living what she defined as a normal life until all of a sudden she collapsed and found out that she had heart failure she had never known, and she now, the only way to survive was to get a heart transplant. So overnight, going from someone who thought she was completely healthy, she was on one side of healthcare, not this other side. And as I went, she also said to me, I don't do anything religious or spiritual. I said, okay. And she said, and I'm not really ready to talk about it because that feels too hard. I will collapse if I have to talk about it. And in her room, there was a picture of her dog. So I brought Bob with me. And she talked about how safe she feels with animals. And I did not push her. As a chaplain, I rarely push. But as we visited, every time she pet Bob, she told me more and more about what this was feeling like. So another example of spiritual care, and just sort of the last one I have for you is a patient who is middle-aged, who had a medical condition she never knew she had. And she talked to me about how harmful she felt religion had been. And as we talked about the hospital experience for her, she said, I feel so unsafe in the hospital. And I asked her where she feels safe. And she said, I feel safe in my bedroom, and I want more than anything for my husband to come and for us to go to our bedroom and to hold our cat. And for those of you who work in hospitals, there's a lot of tape around things like creating a bedroom and bringing a cat into the hospital. And I feel very lucky that I have wonderful coworkers who are willing to help me with this. But this was our attempt at making, with her husband's help, a recreation of her bedroom, and her cat got a very contained and very defined visit. And she still writes to me. She's since gotten out of the hospital, and she still talks about what it felt like to have moments of safety. And so I share those stories because when I think about my proximity and my perspective as a chaplain, like what can I bring about next steps with this really important information? And the first thing that as a chaplain I think about is how the definition of spirituality in this article is beautiful, and I just want to read it to you. Spirituality is a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, nature, and the significant or sacred. Spirituality is expressed through beliefs, values, traditions, and practices. And I just want to say that with that definition, all of those 4 patients who very clearly said, I am not religious and I am not spiritual, I think that work that her care team got to do with her, that fit this definition of spirituality. And so I think about our opportunity to evolve the language of spirituality to better portray this meaning and definition. And I say that not only as a chaplain, but as a queer woman who has experienced very well how words like religion and spirituality can be very unsafe words. And so while experts know that spirituality is not necessarily religious, the language of spirituality still has religious connotations for so many. And so I pose these questions to you as we think about making our vocabulary better. Where do you find meaning? What are milestones in your life? What do you hope for? When or where do you feel safe? Where do you turn to when you are scared? When are you happy? When are you most yourself? When do you feel a part of something bigger than yourself? And outside of asking those questions as care providers, when we give examples such as religion, pets, nature, literature, traveling, this helps empower our patients to be honest and authentic and to know that all answers are fitting and welcomed. And then using descriptions of spiritual, religious, or belief identities helps ensure that those who wouldn't identify as spiritual are equally included. So how we introduce this is really important. And then I guess the second step is really well connected, and it's about not what do we do as care providers in terms of how we do assessments with our patients, but it's about how do we apply those assessments of what we're calling spirituality to yourself. So to really see the value, to really understand why these questions matter and to get comfortable with asking them, I believe that you have to answer them first. And so I just want to invite you to get a little more comfortable, and just for a few moments, I would like you to have some time to answer these questions in your mind. So taking a deep breath, I would like you to think about a time when you were scared. What happened? What did you need? And where did you turn? Imagine a time when you were happy. What were you doing? And who were you with? What is a milestone in your life from a long time ago or the very close past? Why is this day or this moment so important to you? When have you felt like yourself? Where are you? What are you doing? And when have you felt bigger than yourself? When have you felt connected? Is there a tradition that matters to you? Where did this tradition come from? I believe that as a chaplain, I ask these questions to not only my patients, but my job is also to support my colleagues, the staff members at the hospital. And so in order to ask the questions, it's really important that I take time practicing, thinking through the answers. And by engaging in the practice, we know what it feels like to be asked these questions, which I think is very important. And just the last thing that I'll share is that my kind of third step is I would invite all of you to embed what we're calling spirituality into the culture of the staff in a healthcare setting. So what does that look like? That can start at the very beginning as we interview new nurses, new doctors, new techs. And in the interview process, asking not only questions about their clinical expertise, but asking them, when were you really happy? When were you really connected? Who's someone who inspires you? When you have staff working with you, what would it look like to have boards on the units or in the office where you invite people to have pictures of their favorite places or days of celebration or sources of inspiration? This not only leans into important aspects for staff, but it models what we call spiritual care for patients. If they're coming into a space where this is practiced for the staff and it's part of the culture, it's going to feel a lot more natural to them. So thank you so much.
Thank you, Allie, for those moving stories and those very moving questions. And last but not least, our wonderful colleague, David Rossmarin. Round of applause for Dr. Rossmarin.
Well, I'm not going to outdo chickens and tutus. It's a real honor to be here. As I mentioned briefly to Tracy at the beginning and also to Tyler, this is in many ways celebratory for them and for all the authors on this. To have a paper like this in JAMA is a big deal, a very big deal for the entire field. I'm coming at this as from the perspective of psychology. I'm a clinical psychologist, and I'm at McLean Hospital. I direct an interesting program there called the Spirituality and Mental Health Program, and that's not how I started. So I'm gonna begin with a story, kind of like everybody else here. I guess in the Divinity School, you tell a lot of stories. So when in Rome. So I joined McLean Hospital and the Department of Psychiatry there as a clinical psychologist and doing clinical work in the cognitive behavioral and dialectical behavior therapy units with acute psychiatric patients. And I came there in order to learn how to do CBT and DBT in the trenches. I'd done a lot of outpatient work before, and this was inpatient. And I'm from the Orthodox Jewish faith, and I wear my yarmulke proudly. And within a couple of weeks of being there, patients were coming over to me. And, excuse me, can I talk to you about God? why am I depressed for why am I impatient for the 6th time in the last 12 months? Like, why is God doing this to me? So I would just be, kind of scurry off when they asked me these questions because I didn't want to get fired, at least not in the first month. But after, 8 or 9 of these encounters, I went to my advisors and I said, what do you want me to do when the next patient comes over to me and says that they want to talk to me about God? Like, I'm here as a clinician, like, this is not my job. I'm not clergy, like, I'm the wrong address. And I guess, like, I'm giving them a cue of this, but something has to be done about this. So I remember my atheist advisor, Dr. Throster Bjorgvinsson from Iceland, leaned across the table and he pointed his finger at me and I'm like, uh-oh. And he said, Ross Marin, you got to do something about this. Many of our patients have spiritual needs. And believe it or not, at that time, McLean didn't even have a chaplain. So he said, we're not taking care of our patients' needs. And it's probably not all of them, but it's enough that we have to do something about this. And the next thing I know, I designed a spirituality and CBT group, which was implemented at the unit. It quickly became one of the most popular in the entire program. That was after the fight during the staff meeting about whether this is a good idea or not. I did not prevail. What I did is I said, listen, let's study this and actually be scientists about it. And that was enough to quell the fires. And we did that, and we've published our work ever since. What's important with just sort of circling back to this JAMA piece is that there's such a disparity, especially in mental health. And a lot of the outcomes here, the health outcomes were related to mental health. I don't know if you caught that when Tracy was speaking, whether it's suicidality, alcohol, substance abuse, depression, overall happiness. These are many of the things that people come into medical as well as mental health settings for care for. So in many ways, this is a wonderful summary of the work on mental health and spirituality, a subset of medical. But the main point I'm trying to make here is the disparity between how we address this issue in the academy as scientists, certainly, and even as clinicians, versus how much it is a need on the part of patients. There is an incredible disparity, and especially in the world of mental health. Dean Hempton, at the beginning, you started off talking about this exile of illness and how people are either, we're all citizens of one and hopefully staying in the health camp. And we can see very readily how humbling it is that at any moment in time, the passport could change. And that in of itself, I think if we just bring ourselves there for a moment, it's not hard to get to a place of spirituality when we enter into that extremely vulnerable space, which is part of being a human. I see this every day in practice in mental health, how vulnerable people are and how they have no choice but to face that in the care that they receive, in their depression, the throes of their depression, their addiction, their recent suicide attempt. And when I sampled our patients at McLean Hospital, take a guess what percentage said that they had significant interest in spiritually integrated care. The answer is 60%. In Eastern Massachusetts, at a psychiatric hospital of patients who want spiritually integrated care. That blew me away. It was 3 times as much as I was expecting. But we see here the reason why. It's related to health. When people conceptualize spirituality in a certain way, it leads to certain outcomes. It's related to certain outcomes. One thing, though, that I think is important that to mention, which has been touched on by some of the panelists, and I think is less so in the paper, is that spirituality can be positive and it can also be negative. And I see this a lot at McLean Hospital, that patients come in with spiritual struggles. Like that patient who asked me, why am I depressed for the 6th time this year, right? Why is God doing this to me? I don't have answers to that question. I certainly don't from my clinical training, and beyond that, it's not really my job. But it is my job to encourage them to ask those questions and to sit with them and to validate that those are real issues, as opposed to changing the subject like many of my colleagues do. And, when we quantify the effect of spiritual struggles on things like suicidality, it's very significant. In some of my work, I've been able to account for 40, 50% of the variance in people's suicidality at the beginning of their psychiatric treatment, just in terms of a very cursory 3 or 4 item measure of spiritual struggles. That's a large percentage that's going on. And I think that the more we study both the positive and negative effects of this area, the more it's part of a dialogue and a discussion. You know, Ali and Anna, I was very moved by your presentations and the idea of psychological safety and the fact that this is just part of good care. When you're talking about spirituality, you're just providing good care to patients, and being very broad in the way that's conceptualized humanizes the process of people coming in for treatment. I still think, though, that spirituality and religion, for that matter, are a very specific part of the equation that is often neglected, even if we're providing humanistic care. And this is, again, especially in the academy. I'll give you one statistic, which I think is quite chilling. There are 90,000 studies which are currently funded by all 27 institutes and centers of the National Institutes of Mental Health, National Institutes of Health, the NIH. Of those, less than 20 out of 90,000 have the word spirituality anywhere in the abstract, and only one has it in the title. That's a disparity of certain identities which are not part of the discussion when it comes to academic work, and it's no wonder, therefore, that we need to celebrate such an amazing paper as this, an amazing contribution. And with that, thank you very much.
Thank you, David. You have such a fantastic perspective on all this, and to have your on-the-ground experiences to share is very moving. So we have some time for questions, not a lot. We also will have time at the reception for you to mingle and chat more informally to one another and to the panelists. We have some colleagues with some microphones ready to go, and let's do this. Can we take the first round of questions, and let's see if we can get through some of them and have the panelists react. So we got a hand back there. Just please stand up, tell us who you are, and ask your question. And I'm going to try to write down the first wave here and see if our panelists can react. Okay?
Sounds good. Thank you. My name is Michael Ferguson. It's so good. Huge congratulations. I love all the comments. I'm really curious, David, to pick up on this insight at the very end here, and I would love to hear all of your perspectives on what we can do to help rectify this disparity. Do we need more mechanistic hypotheses about spirituality, more precision-directed spiritual therapeutics, or is it really just fighting the good fight for culture change? How do we begin to address that disparity practically? Thank you.
Okay, Michael, thank you. Other questions? You've got them? Yes, Dr. Lee. Microphone for Dr. Lee.
Thank you. I'm looking forward to the reception, so I'll keep it very short. I have 4 little items to talk about. In 1950, about spirituality, healing, and God, any God. In 1954, my height weighed 80 pounds, yellow as a yellow sheet of paper. You were 4 years old. This is my younger brother. Nobody could cure him. He went to every hospital in Malaysia and Singapore. Finally, he checked into the Seventh-day Adventist hospital, and he was cured after 3 operations. And in that little hospital with 12 beds, my father has an abdominal problem. There's a craniotomy, a broken hip, a urology problem, so on and so forth. And this one surgeon cured them all. So when I became a doctor, I caught up with him. I said, Dr. Brusky, you must be trained in Mass General because they pride themselves in training everything, right? Not a year where I am. He said, no, I'm a general practitioner. I have 2 things. I have the atlas of all the surgery, and I have the Bible. I prayed, and my father lived to 82 years old, healthy. The second story is, quickly, I have fibrosarcoma of my back. While they were operating on me, my wife, Linda, was on the porch with her girlfriend. And as timing-wise, as they were closing my surgery and cured me subsequently, I'm still alive, 82, she saw an image reflected from her sandal, the image of a fish. The third little story, I was taking care of a professor of law at Yale, and when he walked out and saw a picture of Jesus in my office, he came back. He said, Dr. Lee, I'm disappointed. I thought you are a professor of surgery at Yale. You will not be seeing me as a patient anymore. He walked out. 6 months later, God has it, or whatever, his wife came out with laryngeal cancer. He took her back to see me, and on the way to the operating room, he said, Dr. Lee, would you please pray before you operate on my wife? And she lived to 92, okay? Anyway, so in the interest of all this spiritual, God, okay, can't pronounce that word, our family has endowed a C.T. Lee Fund, my father's name is C.T., about this topic at Yale, Columbia, and at Harvard. And this is what we hope to propagate, and it's a good start right here, because academic institutions are so shy to talk about this topic. And then to talk about what patient want, another philanthropist and I started a foundation called TPIU, The Patient is You, because we were sitting around and wondering, what is compassionate care? What do patients want? Very easy. If you were the patient, what would you want? That is your answer, and I thank you all very much for spearheading this, and I hope there'll be more to come, and people are less shy talking about spirituality and healing. Thank you so much.
Dr. Lee, that's great. It's so moving to hear all these personal stories, I must say, to back up the literature and the science that Dr. Balboni reviewed. Maybe one more question or comment back here. Please tell us who you are and what your question is.
Thank you. Hi, my name is Dr. Ila Farajallah, and I'm so grateful for everything that's been shared today. I feel like I've seen the universe that you are describing. I practiced in the Middle East for a little bit, and back in 2014, when there was a smaller wave of COVID that was taking place, I remember I sat in a room as big and beautiful as this, and we talked for an hour about how to protect ourselves and the patients from the illness. And right at the end, the head of the department got up and said, to summarize, wash your hands, wear your masks, and he put up on the presentation, read these verses from the Quran, and God will protect you. So it would be great to see that kind of integration across the disciplines. I just kind of want to plant a seed in the panel's head before they respond about the situating of spiritual care within minority communities. I took a class at the college last semester, and I came to know an individual, to protect confidences, I won't say who, and they were suffering, a Black individual, and they were suffering from a simple case of gastroenteritis. They crossed the street right over here, went to Harvard University Health Services, and it was a 10-minute situation. No one talked to them, no one explained anything to them, no one even took a full history, just a simple case of gastroenteritis. And when I came to know of it, I just sat with this person, talked to them for 30 minutes, took a full history, and did an abdominal examination. And to my mind, if I was being tested on this back home in Sudan, a case of gastroenteritis, and you don't even take the time to lay the patient down on the couch and touch their abdomen and check for the basic, just do a full examination, I was completely shocked by that. And when I finished speaking to this individual, I remember they looked at me and they said, thank you so much. You have healed me. Don't leave me alone with these white people. So if I could, my question to the panel basically is, beyond training, how can we train clinicians to become less clinical and more caregiving, not to what we refer to as patients, but rather as care seekers? Thank you.
Okay, let's have the panel just weigh in very informally on this. I don't know if people want to comment informally about the first question, what to do, how do we address the need here and change the culture? reflect on Dr. Lee's stories and his call for more philanthropy, and then our last colleague talking about the need for integration and training and more clinical intention to all this. Anybody want to have some quick responses? Ah, Dr. Balboni, she's always the leader. Have you noticed that?
Well, I think it's important to name, and this comes up a bit in just what David shared with us as far as the number of NIH grants that go to this sort of research work. But a larger issue is dollars and where money goes. And even in the story that was shared about the time spent with the person coming to the clinic for gastroenteritis, I mean, a lot of that is because of the fact that money is driving the system. It is, it is primary, and that is not the way that healthcare originated. Healthcare comes; its primary call, the caring for the sick, is not something that's necessarily financially advantageous, right? It comes from our humanity, that it's the right thing to do to care for the sick, and yet we're allowing finances to dictate how care is delivered. And that needs to change. I mean, that's a fundamental culture shift that needs to happen at many levels. It's not right for a primary care physician to only have 12 minutes of time with a patient. So I think that's kind of a grounding foundational thing, that medicine cannot be fundamentally grounded on finances, on money. It needs to be serving medicine, not dictating how it's run. And that's too much the case today. And certainly that trickles down to research dollars as well. But definitely the business of medicine is a primary issue that needs to get addressed.
Thank you, Tracy. I might want to ask Anna, you have some very important jobs and have a very important role as Vice President of Blue Cross Blue Shield of Massachusetts. So you got a real systems and payers point of view in all this. Do you want to make some quick comments to what Tracy and our colleagues have asked here?
I will start with pleading Canadian, which I am. And I really enjoy that moment in every meeting that I'm in. It's about 45 minutes in of an hour-long meeting where these sort of things, like when you realize the root of so many of these challenges, we're like, aha, capitalism again. I think I moved to the States. Like, one of the reasons why I came here is because there are opportunities. I lived in the UK before I came here, and there are some of the challenges that are uniquely American, and there are some of our challenges that are not. And I think the way that money runs through healthcare in these different countries that I've lived in and studied, it is different here because of the fragmentation. It's sort of magnified in so many ways by the way we have chosen to sort of finance and structure our care. I was a Harvard School of Public Health grad many years ago, and one of the first projects I worked on was with the state of Vermont. And Vermont really wanted to change its entire state into a single payer health plan, a la Canada or England, the NHS. And it's really challenging, both politically, operationally, all those sorts of things. So I think the reason why I've stayed at a health plan, because nobody says when they're 25, when I grow up, I want to work at a health plan, is because the opportunity you have at an organization like a health plan to make really, really meaningful differences that are going to impact the care for potentially millions of people. And I feel incredibly unfortunate because Blue Cross has just tried to be a thought leader, both for Massachusetts and for the rest of the country in so many different ways. But we are limited in the set of tools that we are used because we are operating in the framework that, our country frankly decided just after World War II. And so I think the areas where I think we have levers for change are how do we measure what good care looks like? How do we pay for that differently? How do we reward primary care so that it's if we're just trying to pay for individual services, it gets really challenging. But if you're trying to think more holistically about what it looks like to reimburse systems of care that are prioritizing that feeling, a lot of what we're talking about is that feeling of being cared for. And the best way to measure whether you're feeling being cared for is to ask people if they feel like they are being cared for. And I think, we can get into the science of who should be asking and the kinds of questions. One of my big reflections is language has come up so many different times in this conversation about how we describe them, describe the things that we were talking about. But I think we are limited in the tool set. I think those tools exist, and I'm excited that there are health plans like mine that are really trying to think about this differently.
Thank you, Anna. And your presence here means a lot, so thank you so much. We have literally about a minute left, so David, Ali, or Gloria, you want to make a quick final comment?
I want to acknowledge the truth of the case that you presented. And I have seen these cases over and over and over again. And racism is real. And some of the challenges in terms of the finances is a function of race. And I remind my colleagues, our hospital institutions, they're sterile in terms of bacteria, but they're not sterile. All of the evils that are out there are in here. And racism is very much the case. That said, I have never felt more encouraged. Coming through this pandemic, I got stories. And nevertheless, I have never been so encouraged coming out. Because I have colleagues like this. We're regular. This is my girl. So we have these kinds of conversations all the time. And I'm encouraged by clinicians that I do meet who really do want to address some of these issues. I am encouraged by the extent to which a number of hospital systems, and I know at least people in this area, really seem sincere in terms of addressing issues around equity, not only in terms of patient care, but who works in their spaces. We are starting to get some measurable outcomes, and we can measure these things. Now, I don't want to say, I'm saying I'm optimistic. I don't know how long Black lives are going to matter. But in this moment, I'm holding people accountable around what they said they were going to do. And I'm in it, and you're in it, and I suspect this room is full of people who are naming it. I didn't even realize the system was this bad. It is so bad. I can't even say it's broken. It was never designed to work for people like us. But we are not going away. And we will continue to press the issue, and we have partners. And I want to think the thing that I don't finish, you finish. So we're here, and we're not going away. And it's Black History Month, and Black lives do matter. They always mattered, and they always will matter. And we will continue to fight for the justice that we deserve.
Thank you. Thank you, Gloria. We literally have a minute for a final comment by David and or Ali, just very briefly.
I guess I'll, Michael, you asked a great question before about how do we address the disparity. Dr. Lee, I think you provided the answer. And it takes a lot of strength. And I think actually, Dr. Whiteham, what you just said now, in some ways, it takes a lot of strength to bring your own identity and part of who you are to the workplace, and to do so in a healthcare setting when that identity has a spiritual and religious component takes guts. And to stand up and to say, hey, this is interesting, let's study it, without, colleagues at first are gonna look like, what? Like, what do you want to study? Why? There's no funding in that. There's no career in this. Why would you do that sort of thing? But, Michael Ferguson, your paper in biological psychiatry, and you look at what Tyler's doing, you look at what Tracy's doing, what Howard's doing, and I see John Petit here in the audience. There's a lot of people out there in academia, in our department, in our university, who are doing this kind of work and who are saying, no, this is an important part of patients' lives, this is an important part of my life, in whatever way it is, and I'm going to study it, and I'm going to do that proudly. And I think that's really what's going to shift things. Ultimately, is the guts that people have to stand up and to actually research this and to make it into the venerable science that it deserves to be.
David, thank you. Ali, final comment from you, very briefly, and then we'll turn it back to Laura.
Nothing that would just be a minute. I would just say, we're going to be around at the reception, so really looking forward to the chance to talk more about the questions that didn't get to be spoken.
Thank you. So what an invigorating panel and speaker. And this is great to just bring this all out and bring everybody together, and I can feel the energy here. So thank you for your time and attention. I'm going to turn it back to Laura Tuak, who will close this wonderful evening.
I don't want to say much. I just want to say thank you for coming. Thank you to our panelists, to Howard, to Dean Hempton. We have food and drink. It's in the Braun Room, and you're going to take a left here and then another left, and it's all the way down at the opposite side of the school. You are welcome. It's a small room compared to this one. So we hope that you'll enjoy some networking here in this room and in the hallways, and if you find your way down to where the food is, there as well. So thank you for coming.
Sponsors: Harvard Divinity School and the Initiative on Health, Spirituality, and Religion at Harvard University.
Copyright 2023, the President Fellows of Harvard College.